Hello, I'm Kerry Grimes, a service support pharmacist with CPNI. Welcome to this Pharmacy First training for emergency hormonal contraception. Birth rates in adolescent females in Northern Ireland and the UK are still amongst the highest in Europe. The Emergency Hormonal Contraception Service will ensure that women and young people have timely access to EHC when clinically indicated. This should contribute to achieving a reduction in the number of unintended conceptions in women in Northern Ireland. Today I'll be taking you through the Pharmacy First EHC service, including eligibility, safeguarding issues, the EHC consultation, the documentation you must complete, service remuneration, and the next step for contractors and their teams. This CPNI training webinar is to be used in conjunction with the HSCB ECHO training session, which was delivered live on Monday the 21st of February 2022. A recording is available on the ECHO Moodle site. The ECHO recording must be viewed by all pharmacists prior to service delivery. Pharmacists must be registered with the ECHO to view the recording, and any problems accessing the training, please contact Elaine Kane. There are other training modules available on NICPLD's website which are highly recommended, including a recorded lecture on oral emergency contraception, a pharmacy practice e-learning module, safeguarding children and vulnerable adults, and a public health e-learning module, emergency contraception. These various training modules extensively cover the evidence base for selection of emergency contraception method, safeguarding young people and vulnerable adults, and counselling and support, but we will do a brief recap of some of those topics in this webinar. The service can only be provided from participating community pharmacies where the contractor holds a contract with the HSCB to deliver the service, a copy of which is available on the primary care intranet. A copy should be signed and returned via secure email to the local HSCB office before commencing the service. The contractor should ensure that pharmacists providing the service are trained, competent and available to deliver the service. Pharmacists must undertake the relevant training to ensure clinical care competency prior to commencing service delivery. The contractor should ensure that a standard operating procedure is in place, which is in line with the service specification. They should ensure that patient group directions relating to service delivery are organisationally authorised and signed by the appropriate person. The PGDs to be used for the service are available on the primary care intranet. The contractor should ensure the service is available during all of the pharmacy's opening hours where practically possible. The service must be provided face-to-face by an appropriately trained pharmacist in person, and this can be facilitated by video consultation only in exceptional circumstances. The consultation is between the woman or young person and the pharmacist, with no exceptions, i.e. no third-party consultations. The pharmacist is responsible for ensuring the service is user-friendly, non-judgmental, client-centred and confidential. The service is available to any woman or young person aged 13 years or over, registered with a GP in Northern Ireland. Anyone excluded, for example not registered with a GP, should be signposted to other services such as out of hours or a sexual health clinic, or encouraged to purchase EHC over the counter if appropriate. The legal age of consent to sexual activity is 16 years in Northern Ireland. However, surveys suggest that around 1 in 3 young people in the UK have had sexual intercourse by this age. Currently, under 16s are unable to purchase EHC via the community pharmacy and have to seek either a prescription from their GP or access it via a sexual health clinic. This delay in access may have led to a rise in failed EHC for this age group and, as a result, having to access early medical abortion services in Northern Ireland. It is hoped by giving free access to the most appropriate EHC in a timely manner, with supporting advice from you, a trained healthcare professional, about the risks of STIs and use of regular contraception, will reduce the incidence of unplanned pregnancies, especially in this age group. Access to free EHC for 13 to 16-year-olds via community pharmacies is available in other parts of the UK, including Scotland, which has demonstrated positive outcomes, including a reduction in unplanned pregnancies. I appreciate there are additional safeguarding issues for you to be aware of for a young person under 16 accessing this service, and these are covered extensively in the ECHO training. Although unlawful, mutually agreed sexual activity between under 16-year-olds would not generally lead to prosecution unless there is evidence of abuse or exploitation, but I will cover safeguarding later. This service can only be provided by pharmacists who are registered with the Pharmaceutical Society of Northern Ireland. Pharmacist independent prescribers must be registered with the PSNI as an independent prescriber. They must be working in the pharmacy contracted to provide the service and competent to provide the service. It is the responsibility of individual pharmacists to have suitable indemnity insurance cover. Any additional costs incurred to meet the requirements of this service will be met by the HSCB. IPs should submit their invoices to their local HSCB office. Pharmacists acting in the dual role of prescribing and supplying medicines should follow the joint guidance on prescribing, dispensing and supplying administration of medicines. The prescribing, dispensing and/or administration of medicines should normally remain separate functions performed by separate healthcare professionals in order to protect patient safety. Exceptionally, where there are clinical circumstances make it necessary and in the interests of the patient, the same healthcare professional can be responsible for prescribing, dispensing and/or supply or administration of medicines. Where this occurs, an audit trail, documents and processes should be in place to limit errors. IPs are responsible for their own prescription pads, and the HSCB will arrange printing and distribution of prescription pads for this service. More detail can be found in the appendix for IPs in the service specification. The copper intrauterine device, sometimes referred to as the coil, is the most effective method of emergency contraception. All individuals should be informed that insertion of the copper coil within 5 days of unprotected sexual intercourse or within 5 days from the earliest estimated ovulation is the most effective method of emergency contraception. Pregnancy rate is extremely low, less than 0.1% with the copper coil. When a woman or young person chooses to have the copper coil fitted, she should also be supplied with appropriate oral EHC to take immediately in case she changes her mind regarding the copper coil or there is a delay or difficulty in arranging the coil insertion. When insertion of the copper coil is not possible, the alternate is oral EHC. There are two types of oral EHC, ulipristal acetate, known as ELA1, and levonorgestrel. Ulipristal acetate has been demonstrated to be more effective than levonorgestrel. Currently, across Northern Ireland in primary care, there is a higher percentage of levonorgestrel prescribed than ulipristal. Ulipristal has been demonstrated to be effective for emergency contraception up to 120 hours after unprotected sexual intercourse. Levonorgestrel is licensed for emergency contraception up to 72 hours after unprotected sexual intercourse. Evidence suggests that it is ineffective if taken more than 96 hours after unprotected sexual intercourse. Ulipristal has been demonstrated to be more effective than levonorgestrel and should be considered first-line oral EHC. Provision of the Pharmacy First service for EHC through community pharmacies will ensure that supply of the most appropriate and effective treatment. A consultation regarding EHC should include advice regarding the importance of ongoing contraception and information about the available contraceptive methods. Any woman or young person not already taking the oral contraceptive or using another regular hormonal contraceptive should be offered a 3-month supply of progesterone-only contraception, desogestrel, by the Pharmacy First service, and we'll cover that later in this training. Dr. Caroline Hunter's slides during the ECHO presentation covers the safeguarding issues in great detail, but thought it'd be a good idea to review those briefly. The age of consent is 16 in Northern Ireland, but the legislation is not intended to prosecute consensual sex between similar aged young people. Children of the same or similar age are highly unlikely to be prosecuted for engaging in sexual activity where the activity is mutually agreed and there is no abuse or exploitation. A young person aged less than 13 years presenting for EHC should be considered as a safeguarding red flag. If the person is under 13 years, the pharmacist has a statutory duty to report the incident to the police. If the young person is under 16 and the other party is 18 years or older, the pharmacist should contact Gateway team for advice, including contacting the police. The offences for those working in a position of trust cover the same kinds of behaviour as offences which apply to the general public, except that, where positions of trust are concerned, the offences apply where the young person is under 18 instead of under 16. So in other words, it is an offence for a person aged 18 or over to have any sexual activity with a person under the age of 18 if the older person holds a position of trust, for example, a teacher or social worker, as such sexual activity is an abuse of the position of trust. If the young person of any age is showing signs of immediate danger, for example, suicidal intent or abuse, the pharmacist should supervise the young person whilst contacting the police. Always inform the young person of your intention wherever possible, preferably with consent. If non-consensual sex or sexual abuse is suspected, follow local process for alerting the relevant safeguarding leads. If the young person discloses any sexual health symptoms or details circumstances of concern during your consultation, they should be referred to their local Gateway safeguarding team. Again, safeguarding is covered extensively in the ECHO training, and details of the Gateway safeguarding teams, including the HSC Trust Adult Safeguarding contact details, can be found in the service specification. To recap, urgent action is required if you suspect danger or self-harm of suicide, disclosure of sexual assault in under 16, disclosure of sexual activity in 12 or under, disclosure of sexual activity in the under 16 and the other person is over 18. You should contact the Gateway team for advice if possible and consider contacting the police. In all cases where discussion has taken place between the pharmacist and a young person or vulnerable adult and safeguarding issues have been identified, document a summary of the discussions and keep a record. In law, any competent young person in the UK can consent to medical treatment, including contraception. Young people over 16 years of age, including those with a disability or impairment, are presumed to be competent to give consent to medical treatment unless otherwise demonstrated. For young people under the age of 16, however, competence to consent has to be demonstrated. If a young person is believed to be under 16 years of age, the pharmacist must assess their Fraser competence. Fraser guidelines refer to prescribing of contraception, not sexual activity. Discussion with the young person should explore the following issues at each consultation. Does the young person understand the advice given? Has the young person been encouraged to involve parents or guardian? If treatment is withheld, is the young person's physical or mental health, or both, likely to suffer? Is it the young person's best interest to give contraceptive advice, treatment or supplies without parental consent? This should be fully documented using the Fraser competency form in the appendix of the service specification and should include an assessment of the young person's maturity to understand the proposed treatment. NACPLD training extensively covers emergency contraception, but thought it would be useful here to recap. So we run through the consultation step by step. During the initial consultation, you should advise all women and young people that the copper coil is the most effective method of emergency contraception. If the woman or young person wishes to have the coil fitted, then she should be signposted to the most appropriate service, GP practice or local clinic, details of which are in the service specification. As you can see from this table, if 1,000 women had unprotected sexual intercourse or UPSI and all used the copper coil, 1 in 1,000 would get pregnant. However, oral EHC should also be given and taken as soon as possible in line with the guidance. This is in case there's any delay in fitting the coil or the individual changes her mind. Next, discuss when the most recent UPSI occurred and whether additional UPSI had occurred in the same cycle. Consider a pregnancy test if the woman or young person has had UPSI earlier in the cycle. Please be aware that pregnancy testing cannot reliably exclude pregnancy if there has been an episode of UPSI less than 21 days previously. Discuss her menstrual history. So you'll need to know this for two reasons. It can help you work out where she is in her cycle and her likely date of ovulation. She is most fertile in the 48-hour window before ovulation, i.e. the highest risk of conceiving. It will help you calculate when the anticipated date of implantation and thus the latest time in her cycle that the copper coil may be fitted. Ask about the first day of her last menstrual period and her usual cycle length. Calculate the earliest likely date of ovulation, so it's estimated as the start date of her last period plus the number of days in her shortest cycle minus 14. For example, if the first day of her last period was the 1st of January and her cycles usually last 28 days, it is likely ovulation would have happened around the 14th of January. Ovulation calculators are available online, for example at calculator.net. Ask about previous use of EHC in the cycle and confirm which was taken and when it was taken. Ask about other factors that could affect the choice of EHC, including whether she is postpartum or breastfeeding. EHC is not required in the first 21 days postpartum. EHC is required from day 21 after childbirth unless all the lactation amenorrhea method criteria are met. That is, baby is getting more than 85% of its feeds as breast milk and is under 6 months. EHC is required from day 5 after miscarriage, abortion, ectopic pregnancy, or uterine evacuation for gestational trophoblastic disease. In the first 5 days, EHC is not required. Note any current medications you may be taking, including progestogens and herbal products, with particular attention to liver enzyme inducing drugs, examples of which are in the appendix of the service specification. If it is currently 120 hours or more since the last UPSI, oral EHC is unlikely to be effective. You should recommend the copper coil if it is currently within 5 days after likely ovulation. If the last UPSI occurred within 96 to 120 hours ago, or the woman or young person is unsure, offer ulipristal acetate. Levonorgestrel is unlikely to be effective. However, if ulipristal is contraindicated, then levonorgestrel may still be supplied. A copper coil should also be reconsidered if UPSI happened within 120 hours. If the last episode of UPSI occurred less than 96 hours ago, estimate the earliest likely date of ovulation, i.e. the first day of her last period, plus the number of days in the shortest cycle minus 14. If UPSI is likely to have taken place less than 5 days prior to the estimated day of ovulation, or the woman or young person is unsure, offer ulipristal acetate. If ulipristal acetate is not suitable, offer levonorgestrel. There is no evidence that oral EHC is effective if ovulation has already occurred. If the last episode of UPSI occurred less than 96 hours ago, estimate the earliest likely date of ovulation. If UPSI didn't take place less than 5 days before ovulation, offer ulipristal acetate as first line, as ulipristal has been demonstrated to be more effective than levonorgestrel, including those with a BMI greater than 26 or weight over 70 kilograms. If ulipristal acetate is not suitable, offer levonorgestrel. There are additional factors to consider when determining the most suitable choice of EHC. Ulipristal acetate should be offered first line, and if not suitable, give levonorgestrel. If the woman or young person's BMI is greater than 26 or body weight is greater than 70 kg, ulipristal acetate is still a first line, but if ulipristal is not suitable, a double dose, i.e. 3 mg of levonorgestrel should be taken. Ulipristal acetate is not suitable for use by women or young people who have severe asthma controlled by oral corticosteroids, nor for use in women or young people taking antacids, proton pump inhibitors, or H2 receptor antagonists. Offer levonorgestrel. If the woman or young person is taking liver enzyme inducing drugs, or is within 28 days of stopping a liver enzyme inducing drug, the copper coil is the preferred option. If the copper coil is contraindicated or not acceptable, offer double dose 3 mg levonorgestrel to be taken as a single dose as soon as possible and within 72 hours of UPSI. Ulipristal acetate is not recommended. If the woman or young person has recently taken a product containing progestogen or progesterone, for example, contraceptive purposes, be aware that the effectiveness of ulipristal acetate could theoretically be reduced if the progestogen was taken within 7 days prior to taking ulipristal acetate, and could be reduced if the progestogen is taken in the 5 days after taking ulipristal acetate. Instead, offer levonorgestrel. Advise the woman or young person that she should take EHC as soon as possible after UPSI. If she vomits up to 3 hours after taking EHC, she should come back to the pharmacy as soon as possible for a second supply of medication. If the pharmacy is likely to be closed, signpost the woman or young person to a late opening pharmacy in the area, offering the service, or an out-of-hours medical centre. If she attends a different pharmacy for a second supply of medicine, it will involve a second consultation. Advise her that her next menstrual period might be different. If she has early mild bleeding or spotting, this is probably caused by the EHC and may not be the start of the next menstrual cycle. She should not regard this time as safe for UPSI. Most women will have a normal period at the expected time. Some women will have their period later or earlier than normal. Advise her that EHC is not 100% effective. She should have a pregnancy test if her next period is more than 7 days late or bleeding is lighter than usual. Advise her that the risk of ectopic pregnancy is very small. However, she should seek prompt medical attention if she experiences severe lower abdominal pain after taking EHC. Give her a copy of the patient information leaflet, Know Your Options. Advise her that EHC does not protect against STIs. Only a barrier method of contraception, such as condoms, can reduce the risk of STIs. It is essential that at the time of provision of EHC, it is explained that EHC provides no ongoing protection from pregnancy. The main mechanism of action of oral EHC is to delay ovulation, and when ovulation occurs later in the cycle, there's a risk of pregnancy if there's further UPSI. You should advise that when available evidence suggests that EHC administered after ovulation is ineffective. If the woman or young person is not currently using contraception, advise her that she would need to use ongoing contraception or abstain from UPSI to avoid further risk of pregnancy. EHC is intended for occasional use and should in no instance replace a regular contraceptive method. There is a significantly increased risk of pregnancy with further UPSI later in the cycle in which EHC has been taken. EHC can be taken more than once in the same cycle, but repeated administration is not advisable because of the possibility of disturbance of the cycle. Any woman or young person not already taking oral contraceptives or using other regular hormonal contraceptives should be offered a 3-month supply of progestogen-only contraception, POP, desogestrel via this pharmacy first service. Few medical conditions restrict the use of the POP, such as known hypersensitivity, and these are included in the service specification. Where appropriate, the pharmacist may provide a 3-month supply of desogestrel 75 mg tablets. If the woman or young person is starting progestogen-only contraception after ulipristal, advise that she should wait 5 days, at least 120 hours, after taking ulipristal before starting desogestrel. A delay of 5 days is required to prevent interaction with the ulipristal and desogestrel. If the woman or young person is starting progestogen-only contraception after levonorgestrel EHC, advise that she should quick start the contraception. In all cases, she should use additional contraception such as a condom or avoid sexual intercourse for 48 hours until the progestogen-only contraceptive becomes effective. Some advice for a woman or young person starting desogestrel. She should take the pill daily with no pill-free interval and at the same time each day to ensure maximal efficacy. She should take it at a time of the day that best suits her to aid adherence, such as teeth brushing. However, it can be taken up to 12 hours after her usual time. If she is more than 12 hours late, she should still take it but use condoms for the next 48 hours. She should take the next pill at the normal time and this may mean taking 2 pills in 24 hours, the missed pill and the next one at the usual time. It is very safe from a medical point of view. She may notice a few side effects in the first week or so, such as headaches, mood swings, nausea, sore breasts, but these are usually very mild and will pass very quickly. It does not cause weight gain. If she notices her appetite increasing in the first few days, don't start eating more, as her appetite will soon return to normal. The one thing she will notice is that her periods will change. They may continue to be regular but be later than normal. After a few months they may stop altogether and they may be irregular. Advise her to give it 3 months to see what happens, but if she's still not happy with what it's done to her periods, she may want to change to a different method of contraception. She will need to contact her GP or local sexual health clinic before the 3-month supply runs out to arrange a further supply. Where a medicine is supplied, it should be appropriately labelled, and the pharmacist must counsel the individual regarding its safe and effective use. The woman or young person should be encouraged to take the EHC medicine at the time of supply in order to ensure compliance. Where supply of a medicine and/or written patient information is indicated for a patient following a video consultation, arrangements for collection of these items must be agreed between the pharmacist and the individual. When treatment is required and appropriate, it should be selected from the formulary and supplied in one of 2 ways. The pharmacist's independent prescriber writes a prescription for the medicine, which is dispensed in accordance with the relevant SOP. The non-IP pharmacist supplies the medicine in line with the service PGD and completes a pharmacy voucher. The medicine is dispensed in accordance with the relevant SOP. A quick recap on EHC dosage and course length. Ulipristal acetate 30 mg is first line, including when the BMI is over 26 or weight is over 70 kg, and it should be labelled as 1 tablet to be taken immediately. Second line, when ulipristal is not indicated, levonorgestrel 1.5 mg POM pack, labelled as 1 tablet to be taken immediately. If the BMI is over 26 or weight is over 70 kg or concurrent liver enzyme inducing drugs are being taken, this should be labelled as 2 tablets taken immediately. Desogestrel 75 microgram 84 tablet POM pack should be supplied as the bridging contraception, labelled as 1 to be taken daily at the same time each day. The EHC consultation form is a useful guide to aid your consultation and will cover the main points of discussion. Next, we'll go through each section which you will be required to complete. Firstly, complete the patient details, reassuring her that the service is confidential. Note the referral method and if the consultation is in person or via video using your secure HSC Zoom account. Next, note the patient's age, 13, 14, 15 or 16. If she's under 16, ask her for her partner's age. If she is 13, 14 or 15 and her partner is 18 or over, a supply of EHC may be made, but it is advised you should contact the Gateway team for advice if possible, including contacting the police. You should share your concerns with the young person and inform her of what you plan to do. Talk it over with another professional and try and obtain reliable contact information and document this in section 6. As previously discussed, if the patient is below 16, she must be deemed competent using the Fraser guidelines to give consent to use the service. If not, speak to Gateway for advice. A referral should also be made if there are safeguarding issues identified. Next, note the reason for EHC request. As discussed earlier, ascertain her menstrual history, the first date of her last period, her shortest cycle length and where she is in her cycle. Discuss if other UPSI has occurred in the cycle and if she could already be pregnant. Ask her about the last UPSI and when it occurred, and if she has used other EHC in this cycle. Next, discuss if she is currently taking any medication which may impact the choice of EHC. Discuss her medical history. If she has a blood disorder known as porphyria, use of the copper coil is preferred, as oral contraceptives may provoke acute porphyria. If she has a severe hepatic dysfunction, refer to cautions in the PGD. However, guidance advises pregnancy poses a significant risk in women with severe hepatic impairment, that the use of a single dose of ulipristal acetate 30 mg is therefore acceptable. If she has severe malabsorption syndrome such as Crohn's or IBD, the use of oral EHC is not contraindicated but may be less effective. If she reports unexplained bleeding, EHC can be supplied but advise her to visit her GP for investigation. If possible, note her weight or BMI. Ulipristal is still first line in those with a BMI over 26 or weight over 70 kg. However, if not suitable and levonorgestrel is required, 3 mg will be required. Discuss if regular contraception is used. If the EHC request is due to a missed oral contraceptive pill or pills and the oral contraceptive has been taken in the 7 days prior, the effectiveness of ulipristal could theoretically be reduced. Consider use of levonorgestrel. This is covered in greater detail in FSRH guidelines. You can make a clinical decision if EHC is suitable and appropriate. If the patient has returned for a second dose due to vomiting, please tick the box to indicate a second supply was made. Discuss bridging contraception and note if it was supplied. If EHC was not supplied, note the reason. Again, discuss the efficacy of the copper coil as first line and give the patient details of local arrangements for fitting. EHC should also be supplied and note which medication was supplied. Note the process for medicine supply, either using the PGD and supply via the pharmacy voucher or via an independent prescriber. Listed then are the advice prompts which we have covered, which you may find as a useful guide during your consultation. Finally, Part 6 is where you detail an onward referral, instances where there are safeguarding issues or the patient is not deemed competent to give consent. Detail the reason for the referral and the response from the organisation. You should ask the patient to sign and date the declaration. A setup fee of £200 will be payable on receipt of a signed contract. A fee of £20 will be paid per consultation for EHC, with an additional fee of £15 per consultation if bridging contraception is supplied. The claim form should be completed monthly and emailed to the local HSCB office for processing and payment of service fees. AP prescriptions should be coded with normal drug tariff codes and submitted along with the usual prescription bundle to BSO for payment. PVs should be coded with the normal drug tariff codes and the pharmacy first code 97003/1 should be added. These PVs should be processed in line with the other pharmacy first vouchers. The cost of medicine supplied as part of the consultation will be reimbursed on submission to the BSO of the prescription or pharmacy voucher as appropriate. This is the claim form found in the appendix of the service specification and it should be completed monthly. Create a patient number and specify the patient age, if and which medicine is supplied, if any, and if an onward referral was being made to another healthcare professional or gateway, etc. Tick which fees are being claimed for, EHC and bridging contraception, and then total at the bottom. This should then be emailed to the local HSCB offices for processing and payment of the service fees each month. In community pharmacy, the patient medication records minimum retention period for adults is 8 years after conclusion of treatment. The minimum retention period for medical records for children and young people is until the patient's 25th birthday or 26th if the young person was 17 at the conclusion of treatment. A record of the consultation must be retained in the pharmacy and be available to HSCB for monitoring and audit purposes. This includes both the consultation form and the Fraser competency forms. If there are any safeguarding concerns following a risk assessment for sexual abuse or exploitation and non-consensual sex, the pharmacist should contact the local safeguarding lead immediately. On these occasions, a copy of the consultation form may also be sent to the patient's GP. For the purpose of evaluation, a service user survey accessible via a QR code is in development. This will not be available for the whole year but will be in place periodically. Pharmacists will be asked to provide clients with the QR code along with their printed leaflet and encouraged to complete this short survey completely anonymously. So what are the next steps for contractors and their teams? You should review the service documentation, and that's available on the Primary Care Intranet and the BSO website. Ensure that all pharmacists have read and signed the PGDs and undertaken relevant training as required. You should sign the contract and email a copy to the local HSCB office. Contractors should ensure appropriate indemnity arrangements are in place. You should develop an SOP and, if necessary, order pharmacy vouchers or prescription pads as required. You should promote the service using HSCB supplied materials, including the Pharmacy First posters, and through your social media channels. You should liaise with your local GP practice to make them aware that you're providing this service. If you have any queries or require support to provide the Pharmacy First service, please contact myself, Kerry Grimes, or a pharmacy advisor in the local HSCB office. Thank you for listening.